Still, it's all about the basics. I say to patients there are two things that we have to get absolutely right, and that is the diagnosis. And in 2019, that includes the knowing very accurately the histology, as well as the, particularly in stage 4 disease, the molecular status as well as the PD-L1 status. The second thing we absolutely need to get right is the stage. If you define stage 1, that's surgical disease. Stage 2 is surgical disease. Stage 3 mostly is chemoradiation. That hasn't changed, but we know incorporating immunotherapy following the completion of chemoradiation leads to a survival advantage in that population. And then we already discussed the stage 4 situation. So I think that diagnosis and stage are incredibly important. They drive what the treatment options are for patients. Most of the advances we've made with regard to the targeted therapies and immunotherapies in stage 4. However, immunotherapy following chemoradiation based on the results of the Pacific trial is a huge step forward. There are a number of adjuvant trials ongoing, both in targeted populations as well as with immunotherapy. So I think all of us are enthusiastic that the advances we've seen in stage 4 disease will incorporate them in stage 3. And at least the first example we have, which is the Pacific data, clearly shows an overall survival advantage based on using immunotherapy in a setting where we hadn't used it before.